My name is Dr. Matthew Collins. For nearly 2 decades, I served as a cardiac surgeon at St. Vincent's Medical Center in Huntington, West Virginia. That chapter ended only recently, when I handed in my resignation. Over the course of my career, I completed more than 3,000 heart operations, witnessed recoveries that bordered on miraculous, and helped patients who had been given no chance at survival walk out of the hospital alive. But the case I'm about to share is the one that shook the foundation of everything I thought I understood about medicine, mortality, and the fragile line that separates the two. St. Vincent's is a Level 1 trauma hospital serving patients across West Virginia, Ohio, and Kentucky. As head of the cardiac surgery department, I had seen every type of critical case imaginable: massive infarctions, rare congenital defects, devastating trauma, even patients who arrived without a pulse and somehow left fully recovered. Nothing could have prepared me for what happened on a cold night in February 2023. I was finishing up my rounds when at 11:47 p.m. my pager went off. It was a message from Dr. Emily Zhao, the ER attending physician. Code blue, cardiac arrest, incoming trauma, estimated arrival 12 minutes, report to OR2 immediately. I hurried to the surgical suite where my team was already setting up. My scrub tech, Daniel Morales, had been with me for more than 10 years. Our anesthesiologist, Dr. Karen Mitchell, was one of the most capable in the state. If any team could handle what was coming through those doors, it was this one. The paramedics rolled in a patient, Andrew Kay, age 37, a construction foreman from Dayton, Ohio. His wife had discovered him around 4 a.m., barely breathing and completely unresponsive. She immediately called 911. Paramedics managed to find a faint pulse during the ride, but his condition was dire. His blood pressure was nearly non-existent, his skin grey, and his cardiac rhythm wildly unstable. We launched into aggressive resuscitation at once. "What's his downtime?" I asked the lead medic as we shifted Andrew onto the table. "Family estimates about 20 minutes before he was found," he replied. "We got a pulse back after 15 minutes of CPR, but it's been unstable the whole way in." That wasn't good news. 20 minutes without adequate circulation usually means catastrophic brain damage. Still, I've learned never to abandon hope too soon. The body can surprise you. For the next 4 hours, we fought for him. His heart would steady, then collapse again. We cycled through every medication, shocked him multiple times, and even debated emergency bypass. Each effort brought only a few fleeting moments. Dr. Mitchell leaned in, her voice grave. "Matt, his pupils are fixed. No reflexes, no response to pain." I checked myself, no pulse. The monitor was flat. His skin was cold and early rigor mortis had already set in along his jawline. At 4:17 a.m., after exhausting every protocol, I spoke the words no physician ever wants to say. Time of death, 4:17 a.m. We had done everything. Andrew had no cardiac activity, no respiration, no brain function. His temperature had dropped to 94 degrees despite active warming. By every standard, he was gone. I stepped out to meet his wife, Claire, who sat with their teenage son in the waiting area. Breaking that kind of news never gets easier. I sat down, leaned forward, and spoke softly. "I'm so sorry. We did everything we could, but Andrew didn't make it. His heart stopped and we couldn't bring him back." Her cry filled the room as she fell into her son's arms. After giving them a moment, I explained they would have a chance to say their goodbyes and that we would contact the funeral home to begin arrangements. What happened afterward defied every rule of medicine I had been taught. At around 5:30 a.m., I was in my office filling out Andrew's death certificate when Daniel, my tech, burst through the door, pale and shaking. "Doctor, you need to come back to OR2 right now. Something's wrong with the monitor." "What do you mean wrong?" I asked. "The EKG is picking up a heartbeat, strong and steady." I stared at him in disbelief. "That's impossible. We disconnected everything over an hour ago." "That's just it," he stammered. "We didn't. We were waiting for the family. The monitor just started beeping on its own." I rushed back, certain there had to be a malfunction. But what I saw as I stepped into OR2 will stay with me forever. Andrew was sitting upright on the surgical table, awake and alert, looking around with steady eyes. "Where am I?" he asked clearly. "What happened to me?" I froze in place, unable to make sense of it. I had declared him dead 75 minutes earlier. No pulse, no brain activity, cooling body, early rigor. By every clinical definition, he had been gone. Dr. Mitchell was trembling as she checked his vitals. Blood pressure normal, heart rate 78, oxygen 98%, temp 98.6. All perfectly normal. How long was I out? Andrew asked, swinging his legs over the edge of the table. I stepped forward cautiously. Andrew, do you remember what happened? He frowned, thinking hard. I remember feeling awful yesterday, like I couldn't breathe. Then Claire called 911 and paramedics were in the bedroom. After that, nothing. Until just now. I ran through a neurological exam. Reflexes intact. Clear memory of events leading up to his collapse. Fluent speech. Rational thought. No sign of impairment. Andrew, I need to tell you the truth, I said quietly. You were declared dead at 4:17 this morning. That was more than an hour ago. No heartbeat, no brain activity. Your body temperature had dropped. He looked straight at me, calm, steady. Dead? Really dead? By every medical measure, yes. But I'm here, he said simply, and I feel fine, better than I have in weeks. There was no way to argue with that. Still, I couldn't begin to explain it. I immediately ordered every test we had: EKG, echocardiogram, blood work, CT scans, MRI. Dr. Zhao, who had paged me hours earlier, arrived to see for herself. She stood frozen at the doorway, her eyes wide. This isn't possible, Dr. Zhao muttered as she scanned the chart. I was standing there when you pronounced him. I saw the flatline. I confirmed the absence of vitals. I know how it sounds, Bess, I told her, but he's right there talking to us, clear as day. The tests came back one by one. Normal, in fact better than normal. Andrew's cardiac output was flawless. His brain imaging showed no trace of oxygen deprivation. His lab suggested every organ system was functioning at peak capacity. Nothing in medicine explained what had just happened. News travelled fast inside the hospital. Within hours, specialists from cardiology, neurology, emergency, and even administration were flooding in with questions. How does a patient return from confirmed death? What did we miss? Dr. Robert Levin, our neurology chief, examined Andrew thoroughly. Later, he pulled me aside. 30 years in practice, he whispered, and I've never seen anything like this. After that length of cardiac arrest, there should be serious deficits. Memory gaps, motor problems, cognitive decline. He has none. The hospital's ethics board called an emergency session. The state medical examiner's office was notified. Everyone wanted to know if we had overlooked signs of life, but I knew we hadn't. I had checked for a pulse myself, repeatedly. I had verified the absence of breathing, the lack of reflexes, the fixed dilated pupils. Andrew had been dead, until he wasn't. As word spread, I started hearing from colleagues around the country who had seen similar cases. Dr. Laura Perez from Cedars-Sinai described a patient who revived after 23 minutes without a heartbeat. Dr. James Holloway at Johns Hopkins recalled a woman who came back after 3 full hours. I dove into the literature. The phenomenon is sometimes referred to as Lazarus syndrome, spontaneous return of circulation after failed resuscitation. The first published description appeared in 1982, but documented cases remain vanishingly rare. The most striking example I found was that of Velma Thomas, a 59-year-old West Virginian who was declared dead for 17 hours before suddenly reviving. Like Andrew, she recovered completely, without neurological deficits. What troubled me most wasn't simply the impossibility of survival, it was the pattern. These patients weren't returning with devastating brain injury, they were coming back intact. Often they reported feeling better than before they collapsed. Andrew remained admitted for 72 hours. I visited him often, trying to understand what he remembered during that time we believed him gone. "Do you recall anything while you were unconscious?" I asked one evening. He hesitated, gazing out the window. This might sound insane. At this point, nothing will. I remember floating above the bed. I could see you working on me. I saw Claire in the waiting area, sobbing. I wanted to tell her I was okay, but I couldn't. That account lined up with near-death experiences described in other Lazarus cases, but Andrew's situation was different. The sheer length of time. He had been clinically dead for 75 minutes. I saw a bright light, he continued softly, and I had a choice, go toward it or come back. I thought about Claire and our son. I chose to return. What made you choose that moment? I asked her. I heard her voice. She was talking to me even though she thought I was gone. She told me about our boy's graduation, about the trip we planned for our anniversary. She said she wasn't ready to let me go. I checked the records. Claire had been at his bedside at 5:25 a.m., speaking to his body. At 5:32 a.m., the monitor recorded his first heartbeat. Andrew's recovery wasn't just unlikely, it was complete, swift, unexplainable. Within 2 days, every one of Andrew's vitals had stabilized. His heart was performing better than it had in years. Neurological testing showed no impairment at all. It was as though his brush with death had somehow reset his entire system. "I've never felt this good," he told me before discharge. "Like I've been given a restart, and my body knows it." His case raised troubling questions about what we really mean when we use the word death. If Andrew could be clinically gone for over an hour, only to return with flawless function, what did that imply about all the patients we had declared beyond saving? How many might have recovered if we had waited just a little longer? The hospital's legal department quickly became uneasy. Were we at risk of liability? Had we made a mistake in declaring him deceased? Could other families claim that we stopped too soon? But I knew we had followed every guideline. Andrew had met every accepted standard for death. The fact that he returned did not negate that. After 3 days, Andrew went home. I continued to see him regularly, 1 week, 1 month, 3 months, and 6 months after the event. His recovery never faltered. His heart remained strong. He went back to his job, resumed his life. On the surface, everything was normal, but the case never left my mind. I began hesitating each time I faced another flatline. I waited longer before calling time. I ordered extra scans, extra tests, searching for any faint trace of brain function. My colleagues started to notice. "Matt, you can't save everyone," Dr. Zhao told me after I pushed resuscitation far past the point most would have stopped. I had worked on a cardiac arrest for 3 straight hours. "How do I know when to stop?" I asked her quietly. "How do I know they're truly gone?" "You rely on the protocols, you rely on your judgment. That's all any of us can do." But Andrew's survival had destroyed my confidence in those very protocols. If we could be so completely wrong once, how could I ever be sure again? 6 months later, another case forced me to confront that question. Walter Williams, a 78-year-old from Lexington, was under hospice care for end-stage kidney failure. One evening, his nurse found him unresponsive. When the coroner arrived, he examined Walter and pronounced him dead at 9:00 p.m. His body was transported to the funeral home. But at 11:45 p.m., a frantic call came to the hospital. A funeral home worker reported that Walter had begun breathing during preparation. He was alive, conscious, speaking, and asking for water. He was rushed back and I examined him personally. To my astonishment, his vital signs were normal. His kidney function, which had been deteriorating for months, appeared dramatically improved. He was clear-headed, calm, not the slightest trace of the confusion usually seen in late-stage renal disease. "How are you feeling, Mr. Williams?" I asked. "Better than I've felt in years, Doc," he said with a laugh. "Is it true they thought I was dead?" "According to the report," I answered, "you were officially declared deceased at 9:00 p.m. Walter chuckled. "Well, that was a little premature." Walter's case convinced me that we were dealing with something larger than isolated anomalies. A pattern was beginning to emerge, one that directly challenged our definition of death. Like Andrew, Walter had been declared gone. Like Andrew, he came back intact. Both described near-death experiences. Both insisted they felt stronger afterward than before. I began cataloguing every detail, building a database of what medicine calls Lazarus syndrome. My search revealed at least 38 documented cases since 1982. Reported downtimes ranged from minutes to hours. Yet in every instance where neurological testing was performed, patients showed no lasting brain damage, despite prolonged oxygen deprivation. Most troubling of all, the occurrences seemed to be happening more often. Whether that was because of improved record-keeping, advancements in resuscitation, or some other unknown reason, I couldn't be sure. As more people learned about my interest in Lazarus syndrome, families from across the country started reaching out, convinced their relatives had been pronounced dead too soon. Fellow doctors began questioning my judgment and abilities. Hospital leadership grew uneasy about what they called my fixation on these rare events. "Michael, you're one of our most skilled surgeons," Dr. Patricia Hriss, the chief of staff, told me during a private meeting. "But your recent choices are raising concerns. You're keeping patients on machines long after most physicians would have ended treatment." "What if they could still recover?" I asked. "What if we're cutting things off too early?" You can't make medical calls based on a couple of unusual outcomes. You know better. But I couldn't shake the feeling that something essential about life and death was slipping through our hands. How many people had we lost because we followed the rules too rigidly, not giving time for the impossible to happen? My ties with colleagues began to erode. My surgery hours were quietly cut back. Soon I felt like an outsider in my own department, the surgeon consumed by the unexplainable. The final case that pushed me out of cardiac surgery came 8 months after Walter Williams. Velma Thomas, a 59-year-old woman from Nitro, West Virginia, collapsed from a massive heart attack at home. Her son discovered her unresponsive and dialed 911. By the time paramedics reached her, she had been without a heartbeat for about 15 minutes. They managed to restart a faint pulse and rushed her to us. I wasn't her lead surgeon, but I was asked to step in when her condition worsened. Despite aggressive treatment, her heart failed twice again after arriving. She was placed on life support while we tried to stabilize her. The EEG showed no brain activity. Her temperature kept dropping dangerously low even with warming devices. After 17 hours of intensive effort with no progress, the family made the agonizing choice to end life support. Velma was declared clinically dead and preparations for organ donation began. I was in the middle of surgery when it happened, but Dr. Williams called me immediately. "Michael, you need to get down here. Velma Thomas just woke up." When I arrived, Velma was upright in her ICU bed, talking with her son. Her complexion, once grey and mottled, was pink and vibrant. Her eyes were alert, focused. She asked for food. "How long was I out?" she asked me. "Mrs. Thomas, you were clinically dead for 17 hours. We had ended life support and were preparing for organ donation." She listened calmly. 17 hours? That's a long time to be gone. "What do you recall from that period?" I asked. "I saw my late husband," she said. "He told me it wasn't my time, that I needed to come back and care for our grandson. The next thing I knew, I was here." Her recovery was just as complete as Anthony's and Walter's. Within a day, her vital signs were normal. Neurological tests showed no damage. Her heart performed better than before the attack. But for me, her case was the breaking point. The hospital feared lawsuits. Colleagues doubted my competence. Families of other patients demanded to know why their loved ones hadn't been given the same chance. I realized I couldn't keep performing heart surgery with any certainty. How could I decide who lived and died when I no longer trusted the very definition of death? I turned in my resignation to Dr. Hendricks on a Tuesday morning in March 2024. "Michael, you don't need to do this," she said. Take a break. Talk to someone. Work through this." "Patricia, I've witnessed 3 people come back from confirmed death. Not near death, not borderline, dead by every measure we have, and they returned intact. That's not supposed to happen." "Rare anomalies occur. You know that. Not like this. Not 3 times. There's something we don't grasp about death, about awareness, about being alive, and I can't keep making decisions with half the truth." I left Riverside Medical Center and settled in a small Montana town where I now work as a family doctor. I treat routine illnesses, manage long-term conditions, and stay away from life or death calls. Still, those 3 cases stay with me. Anthony Yale, Walter Williams, Velma Thomas, all declared dead by standard medical criteria, all returned after extended clinical death, all fully recovered without explanation. What unsettles me most is the thought of the ones we didn't wait for. How many might have come back if we'd given them more time? How many families were told their loved one was gone when the truth was more complicated? The medical world prefers to label these as rare outliers, not reasons to adjust protocols. But I can't dismiss what I saw. I felt Anthony's absent pulse with my own fingers. I watched the monitors flatline for 75 minutes. I signed the certificate myself, and still, he returned. Since leaving surgery, I've kept researching Lazarus syndrome. It turns out it's more common than most realize, though often ignored or left unreported. It defies our most basic ideas of life, death, and consciousness. Some experts think it comes from chest pressure during CPR that suddenly releases when efforts stop, letting blood flow again. But that doesn't explain Velma, whose revival happened 17 hours after resuscitation had ended. Others argue that our standards for declaring death may be flawed, that faint signs of life slip past unnoticed. But I performed those exams. I know the signs, and these patients were gone. The most disturbing thought is that consciousness might persist in ways we don't understand. If Anthony could perceive the room while clinically dead, if Walter could remain aware during embalming prep, if Velma could see her husband during those 17 hours, what does that mean about the essence of being alive? Anthony returned to his construction job, healthy ever since. Walter lived 3 good years before passing peacefully in 2022. Velma is still caring for her grandson, just as her husband told her to. All 3 asked me the same thing. Why me? Why were they allowed to return when so many aren't? I don't have an answer. What I do know is that those cases changed everything. My view of medicine, of life, and of myself as a doctor. The heart that restarted after death will stay with me forever. Not because it was frightening, but because it showed how little we really understand about existence. Sometimes at night I wonder how many others might wake up if we only waited. But that's no longer a weight I can carry in the OR. Some mysteries are too vast for one surgeon. Some questions about death can't yet be solved. The dead don't always stay dead.